So starting again. Okay, Dr. Epstein, I have a question from Joel. He's a newly diagnosed patient. He asks, is it up to me and is it best for me to find a pathologist for a second opinion on my own? How do I do that? And maybe you can also comment on the importance of an independent perspective on these slides. So
sure. So first of all, I'll answer kind of the second question first in terms of, why should you consider getting an independent to reading your pathology? So part of the issue is when you choose a surgeon, for example, or a urologist or internist, you'd hopefully do a little bit of research, you talk to people, get recommendations, but ultimately you're making a choice as to who you're going to. With a pathologist, for your primary read, you don't choose that pathologist. You just get your biopsy done based on where your urologist, is operating on, and the pathology goes to who's ever connected with that urologist. So you have no idea who's reading the pathology. Some of these individuals could be very good at reading the pathology. Some could have a lot of expertise in prostate pathology, but some may not. Some could be pathologists who are just out of practice. Some could be pathologists who are what we call locum tenens, where they're traveling around doing bit piece work from one place to another because they haven't been able to be hired full-time any place. You just have no idea where that pathology is going to for your primary read. Again, the majority of pathologists are good. I'm not trying to say they're not, but you don't know necessarily for your biopsy if that person is good and an expert in reading your biopsies. So because the pathology is going to be the most critical thing that you do in terms of ultimately guiding all decisions, if your pathology is wrong, all your treatment going forward will potentially be wrong. So the pathology is the bedrock of your whole treatment. And so you should make sure that that pathology is as accurate as it can be. And the only way to ensure that, you can ask your doctor who's reading your pathology if, let's say, it goes to somebody who's good and you look that person up and you say, okay, I trust this person, that's fine. But most of the time you don't have that information. And then basically the only way to ensure that your pathology is accurate is to say, I'd like to have a second opinion. And then for the second opinion, you can choose where that pathology is going to, where your biopsy is going to for that second read. In terms of how do you choose that pathologist, there's several different ways. You can get information from your urologist. They may know. You can get information from the internet. You get information from, venues such as this. But ultimately, you want to have it sent to a true expert, somebody who's written books, written articles on the topic, been a leader in the field. It's like anything else in life. The more somebody does something, typically the better they are. So you wouldn't go to a surgeon and want to be the person you wouldn't choose a surgeon who's only done one or two of these operations and you're the third person. Similarly, you wouldn't want your biopsy going to somebody, a pathologist who's just out of training and hasn't looked at a lot of cases. So you want to go to somebody who's seen thousands, tens of thousands of biopsies. And so, you make that decision like anything else in life by doing a little research, whether again, talking to your urologist or, doing research on the internet, but you can find those individuals. And I would say in the United States, currently there's probably, maybe a handful of people that I would trust, reading my biopsy ultimately, currently. I mean, there's more than that good, but in terms of true experts, I could probably come up with, 5 or 10 that off the top of my head.
Roll out the window.
Hey, okay. Maybe you can explain a little bit about your process. And one point in particular, do you look at the first opinion? Do you look at that before you start processing it, or do you look at it afterwards? How does the first opinion fit in with the second opinion?
Yeah, so that's a good question. And I'm just going to move a little bit while I talk to get my batteries to make sure that my phone does not die, since I'm actually using my phone for this. So don't worry about that. So when I get a case, some people ask me, "Oh, should I look at that blind, for example, not have someone, reviewing? I don't want Dr. Epstein being biased by some other opinion." And so the answer is, we get the outside material to look at, to compare, to make sure that we have the right patient, because sometimes labs could send the wrong patient. So we want to make sure we have the right patients. We want to make sure we have the right specimens. We want to be able to make sure that we're also addressing the right question. So I do look at the outside report, not so much, number one, I, in a sense, ignore what the outside report says when I'm writing my own, looking and formulating my own diagnosis, because that's not important. But I do want to look at the outside report to see, number one, to make sure I'm looking at the correct parts, to make sure I'm addressing any questions that they may have had on the initial report. Also, if there's a disagreement with my report and their report after I've looked at it, I want to see potentially what could have accounted for that difference. So when I talk to the patient, I can say, they called it this, I called it this, and I think this is potentially why. But I never am biased by the outside report, because ultimately, I trust my opinion, and that's why somebody's sending it to me. So no one has to be concerned that there's an outside report that might bias what I'm saying. It's only just to make sure that ultimately all the questions are being answered, and that we have everything, correctly. We have the right specimen. And for example, I'll give an example, just like just this week, what happened, why it's important to have the outside report. So I got some slides. It ends up being on a cancer of the ureter, sent by a patient for a second opinion. I looked at the case, and I realized that these are recuts, meaning they're not the original slides. And I look at the original diagnosis, and they say on the original diagnosis, certain finding, but they say the certain finding was only present on a certain slide and not present on all the slides. And I look up the slides that were sent to me, and I realized I don't see that finding. So I can't tell if they were wrong looking at that slide, or I just don't have the right material. So I'm now contacting that outside laboratory, say I need the original material, because I don't think necessarily I have all the representative material to give an accurate diagnosis. So that's just, an example of why we compare our diagnosis to the original, to make sure we have everything that we need to give a full and accurate diagnosis.
So does that happen very often, that they send an incomplete set of slides? And, what's the jeopardy for patients with that?
Yeah, I would say it doesn't happen often. It happens occasionally, I would say. It's not frequent, but occasionally it happens that we just don't get the right slides, or they send recuts. So what happens with recuts versus originals? So what happens is you have a wax block with your little cores or any type of tissue in those wax blocks. And they take a thin slice off of those wax blocks, and they make your slides. Sometimes if you cut deeper into that wax block, the tissue can change and the diagnosis can change. So if they send not the original slides, but deeper levels into that wax block, potentially it may not show the same things. And so it's potential. You should always ask, when the lab is sending the slides, make sure you send the original slides, not recuts.
Okay. Now, Jeff, before I move over to Jeff, there were a couple more questions about your
Okay. Good morning, everybody.
Jeff, one sec. I had a couple more process questions.
Okay.
John asks, what is the cost of a second opinion? And can results be sent directly to patients? And after that, your turn, Jeff.
Yeah, so the cost of a second opinion can vary depending on the institution. Some of them are $500, mine is $450, so some of them may be slightly less, but that's probably roughly ballpark what a second opinion costs. Typically, we will also bill insurances So insurances typically will cover a significant proportion of the second opinion. Sometimes we cannot charge the full, let's say $450, because depending on what insurance you have, we have to charge less. So the charge can vary. I guess what I would say, and I'm not saying it from any ulterior motive, if I were a patient, I mean, and I tell my family members the same thing. When you think of it, $400, $450, $300, whatever it is, to make sure you have the right diagnosis going forward where your life's at stake, to me is insignificant. I'm not saying it's, not a tiny bit of money, but relatively speaking, in the scheme of everything and the cost of all of what's going to happen to you subsequently, is relatively a small price to pay relative to its worth. In terms of sending results to the patients, it's variable amongst, I would say, second opinion pathologists, whether they do that or not. I had to fight for it, so I switched into a new laboratory where I'm currently working. And initially there were some questions that they raised. Can we send it directly to patients? Should we only send it to the clinician? And I fought hard to say, no, the patient's sending those cases to me. We should make it easy for those patients to get their results, not having them to fight and call up the laboratories, which can be difficult to get them a hold of them, or go through the urologist. So for example, if you provide us with your email or your fax number, we will send you a report directly, as well as back to the original laboratory and your clinician. So in the form that we have for consults, we ask you to put your information to contact you, and also where else you would want that report to be sent.
Gotcha. Jeff, why don't you take a couple of questions?
All right. One of our guests asked Doctor the following: do different cribiform patterns, more than size, behave differently pathologically as per pathologists?
Yeah, so just to again explain to everybody what cribiform means, and I use the analogy of Swiss cheese. It's a solid sheet with punched out little holes, just like Swiss cheese. But when you think of Swiss cheese, you can have a big piece of Swiss cheese, or imagine a small little piece with just one or two little holes in Swiss cheese. And that's what cribiform glands can vary from, being very small to large. And there's a growing consensus is the larger cribiform glands are the ones that are associated with a worse prognosis and more aggressive disease. There are multiple definitions in the pathology literature as to what constitutes large, different definitions, and that's a problem. And hopefully at some point in time, there'll be more uniformity and acceptance what is defined as large cribiform. So my large cribiform might be small to another pathologist and vice versa, which is, again, a problem. But nonetheless, and most pathologists don't even report if necessarily there's cribiform glands, and not even even if there are cribiform glands, whether they're large or small. So that's also a problem. But in general, it's the large cribiform glands that are more worrisome. And typically, for example, in relative to active surveillance, would typically be a contraindication for active surveillance if you have Gleason pattern 4 with a larger cribiform gland. There are different types of cribiform glands, and that's I don't want to go into the details. It's not so much the type of the cribiform glands, but really only the size that really is the issue.
Okay, doctor. I have a couple of questions about length. Just broadly speaking, urologists can say length in consideration in deciding about active surveillance. Can you address and define length, how it might apply in our circumstances?
Sure. So length of the cancer has become, I would say, somewhat less of an important parameter than it used to be. And part of that reason is the whole issue of targeted biopsies, for example, under multiparametric MRI. So if you are actually sticking a needle directly into the lesion, you can guide that directly into a lesion that they can visualize on imaging. It makes sense, and it's a fact, that you're going to get more cancer on that needle as opposed to a random core just being stuck, into the prostate in different areas, but not under guidance. So in the past, we had certain guidelines for, what constituted a lot of cancer on the biopsy. Now with the guided biopsies directed into lesions, all those guidelines as to what constitutes a fair amount of cancer probably is no longer applicable. So for me, the volume of the cancer is definitely not as critical as the grade or large cribriform glands or interductal cancer, those worrisome features. Where the extent of cancer on biopsy, I think, can play a role is that, for example, if you have a 3+4 on your biopsy, and every core or extensively a lot of cores are involved, what that means, and the correlation means, is the more cancer you have, typically, not always, but typically the higher the grade. Again, you can have large Gleason 6s, so that's not an entirely 100% rule, but there is a correlation. So yes, it's more worrisome. For example, on active surveillance, if you have a lot of cancer on the biopsy versus a little, not so much because of the volume issue, but just that there's a greater chance that there may be unsampled higher grade cancer with a larger tumor. So it wouldn't rule out, for example, active surveillance if you have a lot of cancer, let's say Gleason 6, or even a lot of cancer potentially with a 3+4 with a very low percent pattern 4. But it would make you more concerned that there may be worse cancer elsewhere in the prostate, and just more of an impetus to be followed up on repeat biopsies.
Okay, thank you, doctor. We have some gentle people from France asking a question. Do you accept slides from another country?
Yeah, absolutely. Just, last week I got a case from London, and so cases from other countries can be sent, glass slides, no problem. There's only a couple issues. Sometimes there's a delay in customs because they think it's biological material and potentially infectious. So you just have to make sure when slides are being sent that it's labeled as non-biological, non-infectious. You can literally just call it glass. So they'll go through. Alternatively, from other countries, and even from the United States, I'm now accepting consults that are scanned slides or digital slides, where the slides are scanned into a machine and then sent electronically via email, and I can read those slides electronically. So that's another option, which we're now starting to do. And the advantage of electronically, slides aren't going to get lost or be held up in customs, et cetera. So it's an option.
All righty, fine. Doctor, regarding costs, a little bit of business question. Does Medicare cover the cost of any and all second opinions?
Yeah, so I would say I don't deal in the weeds very finely with the billing. We have a separate billing department. Typically, insurances, Medicare included, will pay a significant proportion of second opinions. They have in the past, but for your own particular insurance, it's something you would have to, discuss with your insurance company or just put it through and see what happens.
Yeah, Jeff?
Yes, sir.
Yeah, I'm having a little bit of technical issue, but if you could keep an eye out from where the noises are coming from,
Yes, I am.
If you could mute them.
Yes, I am.
Yeah, I'm going to dive in with a couple of questions.
Go for it.
You mentioned digital pathology. Is it true that the digital image is actually bigger than the slide image? Is that possible? Are you able to see more? And how else is digital pathology going to change your field?
Yeah, so digital pathology. So first of all, not all the cost of the machine to scan the slides is in the hundreds of thousands of dollars. So most laboratories do not have the ability to scan slides at this point in time. Now, potentially they could send slides off to a more central laboratory and get them scanned. But it's often much easier for a smaller laboratory just to package the slides and send them, FedEx, for a second opinion. So at this point in time, I would say most laboratories are not using digital pathology to send cases. but it is something that will grow, I think, in the future. In terms of how does it affect, for example, what I'm looking at? So a scan slide is an exact copy of the slide. And it's not just a copy, it's literally a copy that's done at high magnification. So I can zoom in just like I would under the microscope, zoom out, look at things. There are sometimes technical issues with scan slides that can be problematic. If the slide is not particularly flat, or if there was a problem scanning it, certain areas of the slide can be blurry, so that's a potential problem. But in general, I would say it's pretty equivalent when you look at a scan slide versus a glass slide. I would say this in no way is the scan slide better than the glass slides. It's not something that you can see more in the scan slide than the glass slide. So I would never think I better get my scan slide as opposed to glass slide. There's some improvement. That's not the case. I would say it's at the best, it's equivalent. And there's the advantages of the scan slides are not necessarily from me looking at them. It's more from the logistic standpoint that, you don't have to get slides sent physically. They can be instantaneously sent. You don't have to worry about slides being sent back. But there's from a medical standpoint, there's no advantage of the scan slide versus glass slides.
I got you. Okay, now George asks, and I don't know if this is strictly a question for you, but maybe you can help. Is there greater accuracy in reviewing slides to get one obtained from a fusion MRI?
Yeah, so a fusion MRI does have certain advantages in terms of making sure that you are exactly, in the lesion itself. When I'm looking at a biopsy, I can't tell where if I were just looking at the biopsy by itself, I can't tell where it's, a MRI guided biopsy versus a random biopsy. The biopsies look similar. Sometimes transperineal biopsies will look different just because you're going through the skin and you get sometimes different tissue. But ultimately, the biopsies don't look dramatically different depending on the technique. It's more that they are just better sampling a lesion as opposed to randomly being throughout the biopsy. But again, what I've said in other venues is, although the MRI and other guided biopsies are an improvement, and in general will find the most aggressive tumor, every week, almost every day, I see exceptions to that rule where the random biopsies sometimes find the worst cancer and the guided biopsies miss it. So you always want random plus targeted biopsy. If you're having an MRI, you never want just only to target what lesions they see.
Yeah, Jeff, I am unable to admit people. I'm unable to silence people. I don't know who it is. Maybe they're away from their Zoom, but we're getting this feedback.
Yeah, I've been searching for it. I hesitate to mute everybody. I could do that, Howard.
Why don't you do that?
I'm going to do that. And if you want to go ahead, I'll work on that right now.
Yeah, but please put me and Dr. Epstein back.
You took it out of my pocket?
Yeah, I mean, if you can figure out who that is, maybe you can kick them off.
Well, I'm trying to do that. Let's see. In the meantime, why don't you go ahead with another question, and I will work on muting everyone, just so everybody knows.
Patient I had a question from earlier. He had several cores positive. He had Gleason 6. He had Gleason 3+4, but he had more than 2. And so does that put him into the category of high volume prostate cancer? And how does that fit into what you do, Dr. Epstein?
Yeah, so 2 cores or even 3 cores is not necessarily high volume. It would also depend on the extent of the cancer per core. So I've seen many cases I might have five cores with cancer, but each one has a tiny Gleason 6, and that's totally still insignificant cancer and would be, a totally fine candidate for active surveillance. On the other hand, you could have a small focus of cancer, and it's higher grade, and that would be an exclusionary finding for active surveillance. So the volume, again, isn't as critical. So I wouldn't worry particularly, but when I'm talking about high volume cancer, I'm talking about 3 or 4 cores where cores are 50, 60 to 80% full of cancer. That's more what I would consider starting to be higher volume.
Gotcha. I'm sorry to mention it again, Jeff. Are you able to?
Yeah, I'm working on it. I think we should just say that, again, whoever you are, please mute yourself. Yeah.
But can't you mute everybody?
I just tried it.
Okay.
It should have worked. I'll continue working on it.
No problem.
Okay. I'm able to talk to you, but I can't admit anybody. Well, what can I say? It's Zoom, right?
I'm going to keep I'm just going to do a search, Howard. You go ahead. I'll try searching again.
Hey, Dr. Epstein, what is a confirmation biopsy?
So typically you first get your initial biopsy, and let's say it shows cancer, regardless of the extent. Or I shouldn't say that, because if your first biopsy shows high-grade cancer, more aggressive cancer, obviously aggressive cancer, there's no need for a second or confirmatory biopsy because basically you'll need treatment based on that first biopsy. But if your first biopsy does not show significant cancer in terms of grade or extent, and the first biopsy is something that potentially could still be consistent with active surveillance, then typically you'll be recommended to undergo what's called a confirmatory biopsy. And a confirmatory biopsy is done typically within 1 year after that initial biopsy. And the purpose of that confirmatory biopsy is because of the sampling error with prostate biopsies that's inherent in the procedure. So it's not infrequent that that first biopsy may not sample the worst cancer in the prostate. It may miss the highest grade cancer, for example, in that biopsy. And so that confirmatory biopsy is to basically confirm or not confirm that that first biopsy was accurate. That either you do indeed have relatively insignificant cancer, and you, again, could be a good candidate for active surveillance, or that first biopsy was wrong and undersampled more significant cancer, and therefore, that you go with what that second biopsy showed. Now, from my standpoint, if I were considering active surveillance and my first biopsy was not done with multiparametric MRI guidance, I would definitely make sure that the confirmatory biopsy was done with multiparametric.
Howard, you have to unmute.
You have to unmute me or make me a co-host so I can talk.
Yeah. Okay. Sorry, Dr. Epstein, I had to do that to stop the interruption. We're clear now. I'm sorry.
Okay, no problem.
So I continue. Yeah.
Okay. Yeah. So as I said, so a confirmatory biopsy, if the first one was not done without multiparametric MRI guidance, second biopsy should be done with MRI guidance, multiparametric MRI guidance, to make sure that if there is a targeted lesion, that lesion is sampled as well as possible. But that's the purpose of, again, a confirmatory biopsy.
Okay, thank you. Doctor, I'm going to ask you a question. I call it a little bit jumping over the moon, but let me ask you about perhaps the future. I've often asked myself, since we have microscopic and miniature functions that we can do within the body, such as surgery and imaging, do you think the day will ever come where you as a pathologist can manage a tool that actually can look inside the prostate without having to do biopsies?
Um, Medicine always changes. So in terms of what is possible in the future, I would say anything is possible in the future. Things that we can't even envision today, could be possible. I mean, when you think back, we're talking on doing Zoom calls and seeing people's faces on a phone. 20 years ago, that was science fiction. So anything is possible. There's certain, but I would say nothing in the near future approaches that, I would say, currently. There's also talk about liquid biopsy. So rather than having a tissue biopsy, can we detect things in the blood or in the urine that maybe we'll be able to detect cancer with the same sensitivity? So all those are things that are being worked on, but again, not, I would say, close to being prime time.
Right, right. Doctor, a question a little bit off the mark, but nonetheless, one of our participants wanted to use a genomic test such as Prolaris or Oncotype, and his doctor refused to do that. I know it's a sensitive question, but broadly speaking, how would you react if a patient asked you for a genomic test approval?
I mean, we do it all the time. So, for example, in the laboratory that I work, we have certain criteria. We used to have certain criteria, for example, that we would order the test. And there are various tests out there. I'm not saying one is better than the other. Just turns out that in our lab, we use the Decipher test. But again, there are others, Polaris and other genomic tests that, again, are good as well. And we used to have certain criteria that we would use. So, for example, we used to not do it on the very high grade or the Gleason 6s because those, Gleason 6 we know is good. Gleason, the very high grades we know are bad. So we'd use it more for the intermediate where we're trying to say, for example, could you do active surveillance on a 3+4? Or we might do it on a 6 with a lot of cores of cancer to say, is this a Gleason 6 that we could do active surveillance or maybe one we shouldn't? We're now basically going to start evolving to doing it on all cancers, just to give the clinicians that information. What I would ultimately say is that as a patient, if you want something done on your tissue, whether it's being sent for a second opinion, whether you want to direct that to a certain individual, whether you want a molecular test, whatever you want, this is your specimen. It's from you. You own it. The lab does not own that specimen. You should have the ultimate say what should be done with that. And so if you get pushback, I would push them right back and talk to your urologist. And if your urologist says, I'm sorry, I can't do it, I'm not going to do it, I'm not saying get a different urologist, but, potentially that's something to think about. Because ultimately, or at least ask the clinician, why wouldn't you get it done? And if they provide a good answer, then that's fine. But if they don't have a good answer, that's not acceptable.
Right. Okay, doctor. Another question I have is, my biopsy was 2.5 years ago. Can these original results slides still be used for a second opinion?
Yeah, so slides last in a sense forever, as long as they're cared for routinely and there's not too high of a heat or any unfortunate thing happens to them. But routinely prepared slides, literally, I've looked at slides from the 1930s and 40s, and they're still totally fine to look at. So absolutely, 2.5 years is totally not a problem to have the slides being sent off.
Okay, and yet we have another one. Interesting question. I haven't heard this. Is extra staining important?
Yeah, so I would say it depends on the case. I would say 90%, 80 to 90% of the time, what we call the routine stain, which is called the H&E, or it spells out as hematoxylin and eosin stain, H and E, which has been around since the 1800s. It's like the original stain that people have used. 80 to 90%, that routine staining is sufficient to make an accurate diagnosis. In the 10 to 20% of the time, we do use special stains, and the most common special stains we use are basal cell markers and another marker called racemase. And the purpose of those basal cell markers and racemase, most of the time they're used to say, is there cancer versus not cancer? They're not foolproof, and there are a lot of pitfalls using these stains, meaning this sometimes the stains could look like cancer and it's not. Sometimes the stain could be, look like not cancer and it is cancer. So you need, again, an expert to look at these stains and interpret them correctly. But if they're used correctly, those special stains can sometimes change an atypical diagnosis to either definitively benign, and so the patient isn't worried, or to definitively cancer, where then, again, certain decisions can be made. I also use those special stains also to verify whether there's intraductal cancer present or not, because sometimes on just the routine stains, it's very difficult to tell if there's intraductal cancer. And we now have a lot of data showing intraductal cancer is a bad feature and can also affect sometimes decisions, radiation versus surgery, how much radiation, because it turns out intraductal cancer is relatively resistant to radiation therapy and hormone therapy. But also that would be a contraindication, intraductal cancer, for active surveillance. So I'll use that stain for that purpose. And then rarely there are other stains other than the basal cell markers and racemase. Sometimes you might hear the word PIN4 cocktail. That's basically those three stains, two basal cell markers and racemase together. That's a PIN4. But there are rare cases that we use other markers for more unusual types of prostate problems to try to differentiate what's going on. But again, the majority of cases, you're going to see your sign out not mentioning any special stains. The ones you're most likely going to see in your report are going to be called a PIN4 or a cocktail stain, or it's also high molecular weight cytokeratin, P63, and racemase. Those are all terms you may see in your report. What I would say, if you get your report mentioning any of those stains, pretty much don't worry about it, ignore those stains. They were just used by the pathologist to help get to the diagnosis, and just focus on the diagnosis itself.
Okay, doctor, question about geography. I call it geography. I'm sure you have the proper term of the prostate. Gentleman Brett Powell has asked, is a prostate tumor that is in the peripheral zone more likely to metastasize than if it is in the middle of the gland?
Yeah, excellent question. There's been quite a lot of research on that. There are some difference. So about 85% of prostate cancers, if you think of the prostate cancer, and it's not quite accurate, but think of it almost like a donut. So the outer part of that donut is the peripheral zone. The inner part around the urethra where the urine goes through is called the transition zone. So there are some other zones that are not as critical, but for the most part, keep it simple. Transition zone in the middle of the prostate, where typically you have a lot of benign prostatic hyperplasia, BPH, and then the peripheral zone kind of going around the edge of the prostate. So again, 85% of the cancers arise in the peripheral zone, 15% arise in the transition zone.
Okay.
In general, the transition zone cancers tend to be a little lower grade. So you can have a lower grade cancer that's big in the transition zone and it doesn't go out of the prostate, where if you had that same cancer in the peripheral zone, more likely it would go out of the prostate. But ultimately, when you get your pathology report, you don't care whether it's in the transition zone, that middle part, or in the peripheral zone, because ultimately it's only the grade and extent of the cancer, meaning is it in the prostate or out of the prostate, that's going to determine prognosis, not where it's coming from in the prostate.
Excellent, doctor. Thank you. Thank you. Please keep the messages, gentlemen, the questions coming. For those of you who have not used a chat box, it's located in the lower portion of your screen. You just find it. You click on the question box and go ahead and type away and send it to us. We'd be happy to help you out. Doctor, question
So let me
about...
just say, my video is disabled. That's why I'm not on it. I'm not sure if you can do that without messing up the whole muting everybody or not.
Okay.
But anyways, I can keep answering questions.
I will look at that. Sure, I will get right to... Oh, you're not using a video, doctor?
I am,
Okay.
but I can't do the video. It says you cannot start your video because the host has disabled it.
Okay, I will work on that right away because of the other problem. Doctor, tell us a little bit about BPH. Now, I've got what they call maybe I'm heading towards a grapefruit size in lay vernacular. I've got a large prostate. It's up there in the hundreds. Now, how does that relate to the pathologist and my team being able to manage me in active surveillance, if I've got the Hindenburg floating around in my prostate?
Yeah, so good question. And there's several different issues. So one, we don't quite understand why, but it's definitely a fact that the bigger the prostate, typically the less aggressive the cancer. More aggressive prostates are seen in more aggressive prostate cancers are typically seen in smaller prostates. Again, not a perfect correlation, but there's a definite strong correlation with size of the prostate. And part of that could be your big BPH prostate, benign prostate, produces a lot of PSA. That might have caused you to seek medical attention. And then they did the biopsy and found it, for example, a small cancer. Whereas in a small prostate, it's not making a lot of PSA. So whatever PSA is being produced is typically by the cancer and potentially more aggressive cancer. So
Right.
the main thing in terms of following is that you're biopsying mostly the peripheral zone, which is that outer part of the prostate. And so it's not a major problem. The only problem is BPH is more complicated, for example, with ultrasound to look at. And by MRI, it also can be a little bit more complex to look at. So imaging wise, it can be a little bit more difficult to follow cancers on imaging. But again, I would say the good point is that, again, the larger prostates, typically you're going to have less aggressive cancers, but still obviously need following up as well.
Okay, so maybe the MRI is not good. Do we go back to ultrasound? Do we go to micro ultrasound? What would be the best imaging for those of us who have a large prostate, sir?
Yeah, MRI is still better than ultrasound, even with a large prostate, no question about
Uh,
it.
Thank you. Thank you. I have a question here. Does the second read require the CDROM from the guided biopsy?
Yeah, another good question. Absolutely not. I'm not a radiologist, so if you gave me a CD-ROM, yeah, I could probably make some sense out of it, but it's not critical. The critical thing are the slides. So yeah, absolutely no need to send any imaging itself. The imaging was critical to get the biopsies and targeted into the lesion. But once those biopsies have targeted the lesion, it's all on the glass and all on the tissue, and that's all that's needed, not the actual imaging itself.
Okay. There's another question relates to how they calculate the volume per core differently, I guess. Maybe you could share with us how different pathologists may be applying different measurement factors in their practice.
Yeah, so there are different ways to measure the cancer. As I said at the outset, it's the measurement of the cancer is not quite as critical as what it used to be, but nonetheless, we do record the volume. And what I would say that's most important is, again, kind of the extremes, meaning it's not important whether if you have 20% of a cancer versus 30% on a core, that's insignificant. But it does maybe make a difference if you have 5% of a core versus 100% of a core involved. That could be significant. Now, sometimes pathologists will measure the core by percent. For example, as I just mentioned, 100% of the core, 5%. Some pathologists will give actual millimeters of cancer. In general, they tend to correlate well, so it's not so critical whether a pathologist uses millimeters or percent. The only time sometimes you will get a markedly different read in the length of the cancer is in the situation where there's discontinuous cancer. For example, and this is not uncommon, I may see a little bit of cancer on one tip of the core, and let's say I see another little spot of cancer in the middle of the core and another little spot of cancer at the other end of the core. There's two different ways pathologists could potentially record the extent of cancer. One pathologist could say, well, I only see three little specks of cancer. Altogether, that's 1% of that core has cancer. And they may report it as 1% of the core has cancer. The other way is you might say that cancer is discontinuously involving 100% of the length of the core of the cancer. So you potentially could have two different pathologists. One could say there's 1% of cancer in that core, and another pathologist saying there's 100% of cancer in that core. And you would think, how could there be such a disparity? The reason why I report using the second technique, saying that there is cancer discontinuously involving 100% of the length of the core in that scenario, is that we've done studies, other studies have been done, that when you see cancer kind of scattered in a core, it ends up being the same cancer that's a big cancer or bigger cancer going in and out of the plane of section of where that core goes to. So it's not 3 separate tiny cancers, but there's one bigger cancer just not being spread throughout that core. So if you're trying to get an handle on potentially how big that cancer is, it's more accurate to say it's discontinuously involving 100% of that core versus only 1% of that core.
Oh, wow. That's pretty complex. So, doctor, what changes do you see coming to the world of biopsies, particularly for the prostate? And of those changes, are we, the patient, going to be notified? How does the world of your practice communicate other than patient advocates?
Yeah, so it's again a good question, and there are changes in pathology. For example, I was just in a consensus conference on introductal cancer and grading introductal cancer. And so down the pike, we will change in certain scenarios how we grade prostate biopsies, factoring in the presence of introductal cancer. And for the most part, patients aren't going to be aware of that. And it also will take a long time to even filter for general pathologists to start making changes. In my experience, it takes sometimes several years for when the experts make changes for that to eventually filter down to be common practice. But yes, ultimately, patients won't know that changes are there. I would say to some extent you're relying on the experts to hopefully making the right decision. You can read about things on the internet. That's probably the only way to keep up with certain things. But, I would say probably the biggest change that will come down the road that I think patients should be aware about is the whole potential use of artificial intelligence, AI, because that could have a significant impact on your biopsy readings, which, in my opinion, could potentially, in certain cases, have a negative impact. And you should be aware of that. Again, currently, pathology biopsies are not being read by AI routinely. Maybe a few places are, but that's I would say, rare at the current time. But down the future, and maybe not in the far future, AI may be used, for example, in certain places to help grading the biopsies. And they may say, don't send it to an expert, have the computer do it. And it sounds like, whoa, computer can't go wrong. I trust the computer. The problem is the computer for these AI programs are only as good as what's been put into the programs. And so they may not be as accurate as an expert. The other problem is the computer is only as good as what it's been trained on, and computers are not trained on unusual lesions and can make misdiagnoses. Also, the AI is geared to finding anything abnormal, so it tends to overcall cancers and ultimately rely on the pathologist to pick up when it's overcalling cancers and basically not call them cancer. But the problem is some pathologists may also think, oh, it's a computer, it's foolproof. Maybe I should trust the computer. If it's calling cancer, it's cancer, when in fact it may not be. So there's, I think, some inherent problems with AI in prostate biopsies. I'm not saying it may not have some use, but I think just like, for example, I would feel uncomfortable getting in a car in the back seat and reading a book while the car drives down the road. Whereas maybe I'd feel comfortable in the front seat and ready to put my hands on the wheel if there was a self-driving car in a certain problem. And that's the same thing with AI and reading prostate biopsies or any biopsies. You have to be fully engaged as a pathologist when there's AI, sometimes overriding it. But the pitfall is pathologists, again, may not override the system and could lead to problems. So I think that's the main thing down the road for patients to be aware of, just making sure, was AI involved with reading my biopsies? Currently, you don't have to ask that question. It's not happening. But I think in the future, that may be an issue.
Okay, here's a question. The second opinion process. When biopsy slides are sent to pathologists for second opinion, does the lab only send the slides scanned from the first biopsy? And I guess you could add to that question, do they send all the biopsy slides? How does that work?
Yeah, they will send whatever you request. So you have to be specific. If you've had more than one biopsies, and if you want more than one biopsy reviewed, you have to tell them. Typically, they will send the latest biopsy because that's the most critical one that's going to usually determine your therapy. But yeah, it's they have all the old material. They will send whatever you request.
Okay, fine. At this time, Doctor, I do not see any additional questions. Do you have any information you'd like to add, or should we ask the audience to submit, questions that you might think are important to hear from?
Yeah, I mean, right. I'll be glad to answer any questions. What I would say to individual patients who have questions about their own specific case, and I say this, and I've always said this, I'm glad to discuss the case with you, your specific case, and I talk to patients all the time on the phone, but I first have to look at the slides. And the reason why I do that is I have to make sure what you truly have on you is your diagnosis before I can give you an opinion. So if I'm talking to you based on a diagnosis that some other pathologists have read, which may be wrong, then I could be giving you wrong advice based on a wrong diagnosis. And I don't want to be a part of that. So, again, I'm glad to discuss your case, but once I've looked at the slides, I know what the diagnosis is, and then going from that, we can have a conversation as to what I might recommend or what's the significance of your pathology, et cetera.
Okay, Brian, why don't you go ahead and unmute yourself and ask a question?
Jeff, I just wanted to say that the chat box is turned off. That's why there's no more questions.
Oh, okay. I will go right there. All right, I'll work on that right away.
Okay.
Yeah, for now, anybody why don't you just ask your questions verbally? That'll be fine.
Yeah, we're now unmuted, so you can go ahead and unmute yourself, but please don't have noise going on in the background.
I have a question. I'm actually here for my husband. I'm trying to understand how a score given on a prostate biopsy, say it's a Gleason 8, gets downgraded after surgery to like a Gleason 7. Is it because they're just averaging it over a bigger mass? But if it was particular nodules that were localized, doesn't that kind of diminish it and make it less? I'm just trying to wrap my mind around how it can be downgraded or conversely upgraded, I guess.
Yeah.
Well, upgraded makes more sense, I guess.
Yeah, no, biopsies can be upgraded or downgraded. Absolutely. From biopsy to what's going on in the entire prostate. For example, if you have a radical prostatectomy, then you can see the entire prostate. And the whole reason of that is, again, needle biopsies sample just a tiny bit of that prostate. Even when you get a 12-core, 14-core, 16-core, multiparametric MRI guided biopsies, you're still sampling, thousands, 1,000ths of that prostate, depending on its size. So, for example, with the Gleason 8 getting downgraded to a 7, the biopsy happened to hit only pattern 4, so it would be a 4 + 4 = 8. But then once that whole nodule was examined, there was significant pattern 3 there that, for example, the whole nodule ends up being a 4 + 3 = 7. Now, again, important to also look at percent pattern 4. So in the case of a Gleason 8 being downgraded to a 7 at a radical prostatectomy, you would want to know the percent pattern 4. It could be a 4 + 3 = 7 with 90% pattern 4 or 80% pattern 4. Even though it's a 7, 4 + 3 versus an 8, those two diagnoses are not that different, probably prognostically. But if it was a 4 + 3 = 7 with 60% pattern 4 in the radical prostatectomy and the Gleason 8 on the biopsy, yes, that's a significant downgrade. And the biopsy missed a lot of 3. It's also much more common to have probably undergrading, where the biopsy hits a Gleason 6. And if you were to have a crystal ball or a radical prostatectomy, there's 3 + 4, sometimes 4 + 3, and even higher. I mean, I literally just had a case last week, very unfortunate circumstance with an individual who had a Gleason 6, a small Gleason 6 on a biopsy, but the PSA was high. Patient underwent another biopsy 6 months later, and there was Gleason 9 and 10, and it turns out the patient had bone metastasis. So that's the ultimate extreme with sampling error, but it can happen. And that's why every week, almost every day, I will see issues of sampling error where one biopsy showed more cancer than the first. And that's why I always stress to patients, yes, you're a good candidate for active surveillance, for example, but you need to get a repeat biopsy down the road and be followed carefully. Not because your cancer may change to something worse, but that there may be worse cancer there now that's just not sampled.
Thank you very much.
I have a question. I had a radical prostatectomy 5.5 years ago.
Any other questions from the audience?
I think George Diaz had
Yes, I do. Dr. Epstein, thank you very much.
We have. Here's a question from somebody about IDC with no PCA in the gland.
Yeah, so if you have interductal cancer on a biopsy by itself with no prostate cancer, invasive prostate cancer, number one, I would get a second opinion. That's rare. It does happen. And you need special stains to confirm it. But let's say assume it's an accurate diagnosis. There's two different ways to go. One is, depending on your age.
George, go ahead and unmute yourself and ask the question.
Yes, Dr. Epstein, thank you very much. I was newly diagnosed with intraductal carcinoma. It claims that there was no invasive carcinoma, and this was done via an MRI guided biopsy at Northwestern. I will have a PSMA scan. What, in essence, are my options? If, in fact, you confirm it, and I have sent the slides to you, I sent them yesterday. If, in fact, you confirm that diagnosis, what are my options? This is almost overwhelming at this point. Could you touch on that issue, please?
Sure. So first of all, it depends on your age. Let me ask you, what is your age?
I'm 70. I'm very healthy otherwise.
Right. So there's several different options, and it's a controversial area because it is a rare event to find it. Typically, if let's say it's a true verified diagnosis of intraductal cancer, that's, even though there's no invasive cancer on the biopsies, probably 80 to 85% of the time in the prostate there is invasive cancer, typically higher grade. Because of that, typically, or not say typically, because of that, one option is to undergo treatment even in the absence of invasive cancer on that current biopsy. Treatment being radical prostatectomy, I would say probably preferable, just because, again, intraductal cancer is not as sensitive or as well treated with radiation and hormone therapy. There are, however, other clinicians who might say, I don't feel comfortable treating, for example, with a radical prostatectomy or any of the other types of active therapy unless I see invasive cancer. And consequently, another option is to get a repeat biopsy, sampled well. And for example, if the intraductal cancer was seen in the targeted area of the MRI, go back in and even do more targeted biopsies in that region to see what's there, and then base the decision going forward in terms of treatment. So it depends. It also probably depends how much intraductal cancer. I mean, if there's one gland with intraductal cancer, that maybe not have the same significance as more extensive intraductal cancer. So kind of multiple features, I think, would go into making that decision. And, that's the kind of case, once I look at that biopsy of yours, I'll be glad, I think it's, it's something that, we should talk about and discuss some of the options.
Thank you very much. Thank you.
Okay. Anybody else with their hand up?
Yeah. Can you hear me?
Yes, we can. Please go ahead.
Okay. I had a radical prostatectomy 9 years ago, and 2.5 years ago came up with a biochemical recurrence and I identified nodule in the prostate bed. I've been under active surveillance for that. My question is it worth the risk of having a biopsy attempted of that nodule before going ahead with any further treatment?
Right. So there's several things to say about that. First of all, there's a favorable finding that when you have a biochemical recurrence, the longer out from surgery that you have your biochemical recurrence, the more likely it is that it's just local recurrence as opposed to distant spread. So two things. Probably one, I would have a PSMA scan to make sure that the only cancer they see is in the bed, not anywhere else outside of the local regional area of your surgery. Probably that's been done. If not, that's something I would get done. But let's assume the only cancer that they can see by imaging is in the bed. You could have a biopsy of that bed to see if it's lower grade cancer versus more aggressive cancer. Alternatively, just get radiation of that bed. Now, there are side effects with radiation. However, when they radiate the bed of the prostate after radical prostatectomy, much lower doses of radiation are used than when you treat the whole prostate. So there's much less side effects for what's called adjuvant radiation therapy after radical prostatectomy, just targeting a certain area, as opposed to, again, initial treatment. But one way or the other, you definitely need treatment of that lesion. But you want to make sure at this point whether that's the only site where it is. And hopefully, and again, the fact that it's a long distance out, more likely. Also, what was your original biopsy in the radical prostatectomy? Or grade, sorry. What was your original grade?
It was a 3+4.
Yeah, so again, that's favorable. So most likely
with
that
some large Cribopform.
Yeah. But even then, it's more likely it's localized to the bed. If you had, for example, at least an 8, 9, or 10, then it'd be more worrisome that there could be more systemic disease.
What's the likelihood of it being upgraded with a recurrent nodule?
Shouldn't be significant because it's the same tumor coming back. Again, the grade shouldn't have changed in terms of becoming more aggressive. So that's a lot, not saying it can't happen, but not likely.
Thank you.
Okay. We have a few more questions in the chat box. We have one here about gadolinium and a MRI guided box. Do you have any opinion, doctor, on the gadolinium contrast?
No, I would say that's more of a radiology or urology question. I would defer to them.
All right. Another question is, what is a fusion biopsy?
Fusion biopsy is one where the image on the, for example, MRI is more real-time fused with where that biopsy is going to. So it's not like typically often you have an MRI, it shows the lesion, but then when the biopsy is done, it's not done under real time with MRI. It's just going into where they see the lesion on the MRI. So a fusion biopsy potentially is more accurate. I'm not sure there's data to say how much more accurate. And again, it's not widely available in all centers.
Right. Okay. Questions? Anybody from the audience? Mike Wynn, do you want to go ahead?
Dr. Epstein, this is Michael Wynn. You reviewed my biopsy the second time last month. Essentially, I've been in active surveillance for nearly 6 years. And the first report from you saying that I have a large Cribopform and you recommend to get treatment. But then after we spoke with you a second time, you mentioned that metastasis could take years. So can I still be on active surveillance?
Right. So the whole issue about active surveillance is a complicated one, depending on life expectancy, depending on the risks you want to take, how risk averse you are, whether, how fearful you are of side effects of treatment versus, on the other hand, fear of having, potentially side effects of the cancer. What I would say also is when you talk about what's the likelihood of dying of prostate cancer, that is one endpoint. Obviously, it's an important one. But I wouldn't underestimate or minimize the significance of having potential metastatic disease, even though it may take, for example, let's say, somebody develops metastatic prostate cancer to the bone, and maybe it's still going to take 3 to 4 years or 3 years to die after you have that metastatic cancer to the bone. Those 3 years could still be significant side effects with pain, side effects of hormone therapy, which is not insignificant. So I wouldn't only look at just what's the risk of dying of cancer, but I would definitely try to avoid having any kind of metastatic prostate cancer, because that is a serious, serious issue. And so, I can never ask or answer for an individual patient what is the best for them to do, because again, it's a complex decision. All I can say is I think you have a cancer that's more aggressive, one that's typically not treated with active surveillance, that the majority of experts in the field would say, no, you're not a candidate for active surveillance. Ultimately, though, if the patient says, I want to take that chance, that's up to the patient.
For patient active surveillance, doctor, what would you recommend to do to keep an eye for metastases?
Yeah, so in a sense, once you already have, let's say, large cribriform cancer, more aggressive cancer, I'm not sure what biopsies are going to do to change somebody's opinion what to do. So I'm not even sure, do you need additional biopsies? You already have a biopsy saying, again, the experts would say do treatment. So at that point, you just probably get routine periodic imaging or not, and see if you develop symptoms. That's something to discuss with the clinician.
Thank you, doctor.
Okay, Mark, are you on? You want to go ahead and ask a question?
Sure. When we get reports back with large cribriform, PNI, and such, introductal, we know that the papers will show that the outcomes down the road are going to be worse, and often more aggressive treatment is advised. We have good information regarding the outcomes, but not in terms of the effectiveness of treatment, because most of the studies were done prior to PET imaging. How do we, how should we approach these pathological changes when we don't have treatment data that really is looking at a good population of men?
Yeah, good question. First, let me emphasize, you mentioned 3 different findings that could be seen in a pathology report: perineural invasion, interductal cancer, cribriform cancer. So of those, 2 of them are aggressive features, cribriform and interductal. Perineural invasion, I would say, is nowhere near the magnitude of a worrisome feature as interductal and cribriform cancer. Perineural invasion, I would say, is a marginally worse feature, but not enough to probably change treatment, whereas interductal cancer or large cribriform cancer could change treatment. And again, I would emphasize somebody's one pathologist's large cribriform cancer may not be another. So again, you have to be careful with that. And same thing, interductal cancer can have subjectivity and amongst pathologists, and again, a non-expert pathologist could mistakenly call interductal cancer. But let's assume, again, the diagnosis interductal cancer or large cribriform is accurate, and then the issue is treatment. And you're right, we don't have a lot of data in terms of treatment, but we do know that in general, those findings, interductal and large cribriform, are equal to, for example, 4+3s or Gleason 8. They're something that's worrisome. And we do have a lot of data on treating those. I would say we have much more data on treating large cribriform. That's not so an unusual of a feature. What I would say we don't have a lot of data is the treatment of interductal cancer. That's really more, I would say, is a question mark. So when you have a diagnosis of cancer plus introductal, that's more of a problem area, I would say. Because again, there is some data, but not a lot, that it's relatively resistant to radiation and hormone therapy. So maybe favoring surgery. But nonetheless, we don't have, part of the problem with the field of medicine in general and prostate cancer in particular, we don't have head-to-head studies. I mean, you're never going to have a randomized study of some patient getting surgery and some patient getting radiation, for example, with introductal cancer. It just, patients are not going to join those randomized studies. So we never have perfect data to compare one treatment or the other, and we just kind of go with the best we have, but it's imperfect. And you're right, hopefully in the future we'll have more data, for example, treating when there's intraductal cancer. Currently, we just don't have as much data. We have some, but somewhat limited.
Doctor, we have a question. Craig, I'll get to you next. Is your views on the Gleason reforms proposed by Dr. McKinney?
Yeah, so Jesse McKinney at Cleveland Clinic, and I know him well. He's proposing kind of simplify grading into kind of aggressive and non-aggressive. And the aggressive cancer has, large cribiform, has some other features, a desmoplastic reaction, certain other features, et cetera, which I won't go into, versus those that are non-aggressive. And then there's kind of a middle group. To kind of break it into three groups. I'm not sure at this point in time that's it's definitely not something that's being used, I would say, almost anywhere in the country other than probably at the Cleveland Clinic, or I'm not even sure it's being used at the Cleveland Clinic in their reports. It's something more of a research tool. I would say, like anything else in medicine, you'd need a lot more data from a lot of other institutions to show it has significant advantage versus the systems that we're using, like grade group or Gleason grading and some of the other things that we're factoring in. I don't think it adds that much. Then a detailed pathology report listing some of those features like intraductal, large cribiform. It just tries to package them all together and saying this is bad, this is good, or intermediate.
Okay. Craig, did you want to ask a question? Unmute yourself, please.
Yes, can you hear me?
Yes.
Yes, Dr. Epstein, I had a radical prostatectomy 5.5 years ago. The PATH report said intraductal not identified, and it didn't say anything one way or another about cribiform. And I'm now my ultra sensitive PSA is rising towards biochemical recurrence levels. My question is, would it make any sense to have my slides reread at this point with regard to cribiform, or maybe even intraductal, which you said was difficult to see?
Yeah, so I would say once you've had the radical prostatectomy and you're being followed, at this point, probably review of the radical prostatectomy is not going to be as critical as following the PSAs and seeing what's going on going forward. It might give you some indication in terms of, how aggressive the tumor is, but ultimately any decision is going to be based on, do you truly have a recurrence? Is it a local recurrence versus distant? What's the PSA, how fast the PSA is rising? After surgery is another factor. Again, when it rises, how soon to after surgery makes a difference. Also, ultra-sensitive PSA is not the same as just routine PSA in terms of necessarily meaning the same thing. So I would say probably not so critical to review the pathology as much as seeing what's happening with the PSA down the road and potentially imaging.
All right, doctor, I'm going to jump in here, respecting your time and your weekend. Are you wanting to go until 10:30? Is that good for you?
1:30. So in another 1 or 2 questions would be good.
Yes, one other question. Okay, I have one here from Howard, and it's actually a double question, but I'll ask both of them and you see how you do. The first question Howard asks is, can an MRI take over from confirmatory biopsies? And then the second question he asks, most patients don't understand pathology reports. What can be done about this?
Yeah, so I would say MRI biopsies do not take the place of confirmatory biopsies because even the MRI biopsies can miss, no questions, the most significant lesion. So in a sense, kind of the more biopsies eventually, or the more tissue you sample, the more likely you have a more accurate read of what's going on. So yeah, I wouldn't say it supplants it. It's good. It's better than a gut biopsy without MRI, but I would still ultimately have a confirmatory biopsy down the road, even if I had initially MRI biopsy. Now, eventually, if those two biopsies show very limited low-grade cancer, then you can start spacing out the biopsies, spacing out the imaging. All that can start, being individualized. the more reassured that you truly have potentially low-grade limited cancer. And the second question was pathology reports. Yes, and it's a good point. Pathology reports are written in a medical lingo that does convey precisely what's going on medically, and it can be understood by other pathologists. Sometimes not necessarily even clinicians can understand what's written in the pathology reports. So I think that's one of the reasons we came up with the grade group system, again, to make it simpler for patients to understand 1 is good, 5 is bad, versus Gleason, which is very complicated. I think there are some websites, the American Cancer Society, we a long time ago started a website like FAQs about frequently asked questions about prostate biopsies, to try to better understand biopsies and try to break down what you see. So there are websites out there that try to break down biopsies into more understandable language. And now the patients are reading their reports, which was something that didn't exist, 5-10 years ago. Maybe in the future there will be maybe 2 reports, kind of a medical report and then a breakdown or summary report in kind of more common language that can be better understood by patients. Ultimately, at least currently, that's not happening. And so what I would encourage patients is to talk to their pathologist or their clinicians. If they get a report and it's not clear or they're not clear what it reads, talk to the pathologist and ask them questions, or, and it's again, some a pathologist, your clinician should be willing to talk to you about your report and explain them. You shouldn't feel uncomfortable doing so.
All right. I want to thank you, Doctor, very, very much on behalf of Howard Wolinsky. Howard, with the Active Surveiller, is our patient advocate champion. Again, Doctor, thank you for your time. I want to thank everybody for tuning in. Watch and read the Active Surveiller. I want to introduce myself also as a member of Active Surveillance Patients International. I try to help everybody. May your days be long and may your food be delicious. I'm going to end this meeting right now. I wish you all well. Thank you again. Bonsoir.
Thank you for the opportunity to speak to everyone.
Thank you, sir. Bye-bye.
Bye-bye.
Bye, everybody.
Why would anyone set up